Cool. I'll make a smoothie while you do it.
So we're going to be talking all about spine biomechanics this week, guys. I'm just going to go live over Instagram. Are we live there? Oh, don't know if we are or not. Let's try again, Insta. Sorry, guys. Spine biomechanics. So keep checking in, guys. Sorry over the others. Technology is, you only get, just does all the updates and everything. So let's, oh, there we go. It looks like that's working now. So we're now live over on Instagram as well. So we've got Zoom, Facebook, and Insta. Facebook gets a delay. John, Marina, Keris, Brad, we've got you guys. Brilliant. So I know they can hear me over on Zoom. Let me know you can hear me. Hi, Libby, over on Instagram. You should be all right over there. Yeah, good. And then Facebook, they will check in. They're on a delay, so they'll come when they can. Welcome again. So every Wednesday over lockdowns, we're doing these live biomechanics Q&As. That's me, him, and him. So a little mascot over in the background, Broxy the dog. How you doing, Robbie? So this week we're going to talk all about spine biomechanics. So getting some really brilliant questions coming in, Marina. Thank you very much. So my name is Rachel Frantz. I'm a biomechanics coach. I'm passionate about movement and helping others move through education into how the body works, what we should, could, maybe want to do. Hi there, Bev. Hi there, everybody over on Insta. Good to have you along. So we go usually for about 45 minutes to an hour. If you haven't seen any of these, they're all over, they're all recorded. They're all over on the Biomechanics Education YouTube channel. So there's a whole bunch of free stuff on there as well. So you can go and have a little root round as long as you don't get too sick of my voice. And I try to make things generally as practical as possible. Hi there, Neil. Hey, Peter, good to have you in again. So trying to make a very complex subject simple in application. That's really what I endeavour to do through any of these kind of short clips, videos. Please understand the limitation of only having 45 minutes to an hour, which is why having questions in advance is helpful. You can ask as we go. My apologies if I missed one. I will check in all the platforms afterwards, just in case I do miss them. But you can catch me on these pages. You can tag and post questions at any time. Just remember, there is a Facebook page called Biomechanics Q&A. You can head on over there and you'll get notifications in there of any of these going on. And obviously chats around biomechanics and stuff. So today's influence, we've got around about 4 questions. They all kind of come together and they're going to kind of guide me towards the way I want to do it this week. So I'm going to read out the 4 questions, try and put some context around it, because Marina, who's asked those questions, is in our academy right now learning some of our content online. So just to explain where she's coming from, that's where some of the questions, but they are super relevant for any of you. So if you are a personal trainer, manual therapist, Pilates teacher, strength coach, sports coach, physio, podiatrist, osteo, any of these things, or you're a hybrid and you do a bit of all of that, then this is really just to discuss very simple spine anatomy and then spine biomechanics in relation to the questions. So what I'm going to do is I'm going to read out the questions and then kind of run through some anatomy to see if I can't help answer them. So the first one, within our pelvis biomechanics module, we talk about clients rotating around the central column of the spine. And technically, we'd like the spine to be relatively straight, but there are some things that can contribute to risk, even if we tell a client to sit up straight. So I think that might have already explained a little bit for you, Marina. So we should be able to move our spine in all planes of motion. We should. Ideally, that would be great. The better we understand the anatomy of the spine and the joint ranges and capacities in different angles and directions, the better we can understand how well individual clients should be able to move in any direction. One of the problems when it comes to human biomechanics is any research that is done is usually on a group of subjects. Often, if it's done in a university, it might be 20 of the students. So you're getting a specific demographic there. Good studies with 100+ subjects. Stuart McGill does good studies. He gets more of a cross section of demographics, usually indicates more of an average or a mean of joint angles and ranges that we should be expecting to see in clients. So the more research you do, really always check in on the evidence behind any testing or ranges or norms that you come across. However, keeping an open mind to the idea that everyone is different. So research is a great guide. Obviously check the research and where it's come from and the number of subjects and who's done it and how valid and reliable it is. But even when it's a good research study, the data is relevant to that bunch of people. So huge amounts of data around biomechanics is really, really needed. It's just, it can be challenging to do when the body is so complex in so many ways, the way it works as an integrated system. So we've got DGC Fitness over on Instagram, still recovering from chronic back injury in rugby, always keen, stiff in the lower back and often aches when going from sitting to standing. Right, okay, so this is a common issue. So I think you're going to enjoy this session then, DGC Fitness. Sorry, I don't know your name, because we're going to talk around the anatomy. What we can't do, and I know you're not asking this, is diagnose or treat or prescribe for anyone online, certainly not if I haven't seen you and got a full case history. So the spine should move in all planes of motion, and what we talk about in the spine, pelvis spine biomechanics manual is about the relationship between the pelvis and the spine. And if an example would be, and I'm going to talk about the anatomy of the QL muscle in the back. Let's say this muscle, and maybe in the case of my rugby friend over on Instagram, maybe this muscle has altered in its tone. I'm using my words carefully. We could say tight, stiff, overactive, underactive, inhibited. We could use a whole bunch of words in there. It's compensating for some reason that's altering the position between the pelvis and the spine in terms of functionality and alignment. So what can happen then is something that's called, let me step backwards actually, talking about when we move, there are more lower risk positions for the pelvis and the spine's relationship. If one side of the body is inhibited or adapted, and then we move the spine above that or around that, there is more risk. I'm trying to be careful about the language, Marina. I'm going to go into more detail in a moment, but I'm just trying to sort of feed you questions in gradually. So asking whether you should avoid a plane of motion. In general, no. However, what we really need to know in answer to this first question is how much does alignment matter? How can we identify whether somebody is aligned? What's the difference between alignment and function? So we're going to talk a little bit around that. What's more important, and how do we help a client, maybe somebody like my friend over on Instagram, to understand better how to help him move well and get comfortable. So, and do that in a safe manner. Certainly when we're practicing online, we've got to be more careful. So Marina, you can expand on that if I don't answer it by the end of this, but I'm just setting that up a little way because I've got obviously a big audience here. I'm trying to feed in these questions bit by bit. The second part of Marina's question is asking whether when the thoracic spine is stiff or not mobile, does it affect the shoulders? And if so, how? Yes, there's chances are it will. And I'm going to do, in fact, let's do this now. Let's do a quick example of how a stiff thoracic spine can affect shoulder function. So if you're on Instagram, Facebook, or hi there, Steph, or Zoom, you can stand up. Come on, up you go. Come on, it's an excuse to move. You know me by now, surely. Right, okay. So Brad, you'll have done this one before. John, you'll have done this one before. So I just want you to go into thoracic flexion. So a common sort of position or posture for us to see or experience is a stiff thoracic spine that doesn't extend. Yeah, that might be an example. So with your shoulders pulled forwards on your spine in a bit of flexion, and if you're injured, my friend over on Insta, maybe don't do this one. From here, just try and side raise your arms. Yeah, and if your spine is stuck in thoracic flexion, what happens is your scapula are limited in their ability to move around a stiff thoracic spine because they're all interconnected. Yeah. So the more stiff your spine is, the harder it gets to move the scapula that attach onto the thoracic spine. So you can stay standing or you can take a seat again. So that question I think we've answered, and hopefully that answers your question a little bit, Marina. We'll go into more detail of spine biomechanics to really elaborate on that. And Marina's also asked about the emotional impact of this issue. We might think of emotion in body position. If you have experienced some traumatic news, we generally have a kind of posture that associates with being sad, depressed, or emotional. You know, we tend to put hands up to face. This is not my area, by the way, but just sort of human behavior side of things. If you're sad, you generally, or cold, even that kind of temperature can change the way we position ourselves. Certainly emotion. So Marina asked, I once heard that the thoracic spine is connected to the parasympathetic system. Is this true or have I imagined it? Now, this is new for me, so it's not my arena, but I had a quick search, and apparently the thoracic viscera are innervated through both of the sympathetic and parasympathetic divisions of the autonomic nervous system. So I've been reading a journal, and this piece was by, I've got to be careful how I say his name, because it's a guy called Kuntz. So I'm not going to say that out loud because this is a very public Q&A. So Albert Kuntz, PhD, MD, and there's a little blog or a piece that he's written about the nervous system in relation to the thoracic viscera. So I just literally did a quick search, Marina. So I would rather point you in the direction of somebody who's an expert rather than my, you know, almost zero experience in that field. I do think it's linked in terms of osteopathy. I think look at viscera and emotion and pain. And I've had one experience of a client who was experiencing chronic thoracic pain, quite intense. And when I'm speaking to a colleague of mine who's an osteopath, he talked about understanding the stomach in relation to it as well. And I think it just exposes us all to this idea that it's a very holistic thing. The human body isn't just a biomechanical structure. So even though I have a special interest in biomechanics, the way we teach is in the sort of holistic sense of the way the body functions neurally, emotionally, psychedelically. Can't get my words out today. Thanks, Brad. We've whacked a band on it recently, by the way, just for your information. Question number 3 is, okay, if a dysfunctional muscle can permanently change skeletal structure. So first of all, I want to take that statement and just clarify, I've never said that. I wouldn't say that because I can't say that. However, to just take that sentence into context, if a muscle is adapted for a long period of time, and then you're walking. So for example, a bunion might be an example whereby if you have a functionally long leg on one side due to hip biomechanics and you don't address it, you could get changes on one side that alter the way your feet work. So if one side develops more of a bunion than the other, then that can change potentially the way you walk. So if that's what it was relating to, it may be. I haven't said it in relation to the spine. I'm not as knowledgeable in that area. In terms of foot biomechanics, then yes. I guess I'm talking now and I'm thinking at the same time, then why not with the spine as well? So I'll just chuck that in there. So she says, what's the point of doing an exercise to counter the damage? Well, this is where we've got to take into account, a bunion might be a good example. So that might be a common adaptation due to poor pelvic biomechanics, where somebody had a functionally long leg on one side, a functional leg-length discrepancy. The foot is compensated by overpronating, I shall say, for this lecture, where the knee has been more valgus on that side. You've got a buckling at the knee. Over time, the body adapts and compensates by maybe building up a bunion or an adaptation in the structure so that you get a bigger hallux, a ball of hallux on that side, or a bunion, they're more commonly known as. That is going to affect the way you move. Now, can we take away a structural adaptation? Not necessarily, surgically you could, but could you reduce a further onset? Yes, possibly. Because if the adaptation is coming from poor pelvic biomechanics, and we take that away and reduce the load on the foot, reduce the load at the knee, and get the pelvis moving more freely, then we can at least reduce a further onset. Can we take away the bony adaptation? No, not without surgery. My sister had her toes pinned, actually. But I hope that answers that question. And then question 4, in the pelvis and spine biomechanics section of our online workshop, if the pelvis is square to the floor, then the spine can rotate normally, in brackets, and it rotates more or less around the central axis of the spine. Yes. But then the part of the question there is explain what coupling is. And that's what I'm going to go into. So Marine is also asking about John Gibbons, does some great videos, by the way. If you haven't seen John's work, he's the Body Master Method. He does a load of cool videos. He's got some cool stuff over on YouTube. He's an osteopath. But we've got to keep into our understanding different perspectives from different education. So John is an osteopath. He's teaching from an osteopathic mindset, and that is clinical. So what I'm going to hopefully do, Marina, is help you understand Fryette's law, how that sits with in the clinical world, which is not our remit generally. I'm going to talk from the exercise industry, which is where Marina and I sit, and how we understand Fryette's law and coupling in practice, which is where all of these questions kind of come together. So how long does it take me to reel off those questions? 15 minutes just for the questions. But we're going to talk about spine biomechanics. We're going to go through the anatomy of the spine, and then it'll hopefully help me explain Fryette's law, coupling, etc. So I think we've done the emotional side, haven't we, Marina? You all right with that? Yeah, okay. So the anatomy of the spine. I have one here. So we've obviously got different sections within the spine, and if we look in detail at differences between them, for example, we generally rotate most around the thoracic spine. So your lumbar spine has the capacity for around about 2 to 4 degrees of rotation at each lumbar joint. So if you're watching a client rotate, then we might then expect, based on the norms, that most rotation will come from the shoulders. One of the issues is when we rotate, the scapula also rotate. So if we're watching a client move and they're using arms within that rotational motion, can give the impression of more rotation than the thoracic spine is actually showing. Does that make sense? Because the scapula are gliding, giving the impression of thoracic rotation. So we need to keep in mind understanding how we can break down what we know about range and capacity at each area to then put it all back together when we're watching a client move. So we obviously have the vertebrae stacked on top of each other. The lumbar vertebrae are obviously thicker than the thoracic because of the load. They're lower down. The thoracic spine is the area that all the ribs attach to, which is why in Marina's original questions, we talked about if the thoracic spine is stiff, it's connected to the ribs upon which the scapula sit. And the shoulder joint, I've spoken about this previously, is actually quite tenuous in its connection, bony connections. We've talked about there's some blogs on the Biomechanics Education website. We've explored the anatomy of the shoulder joint and how shallow the socket is and how much movement is actually coming from shoulders when we actually want maybe a bit more from the spine. Certainly my friend over on Instagram probably feels like he wants a bit more movement through his spine. Your thoracic spine, if we add up what the norms are through purely the thoracic spine, you should be able to rotate on average around about 45 to 58 degrees from just the thoracic spine without the scapula helping. So a simple way of testing a client for thoracic rotation would be to get them sitting on a chair so the hips are fixed, the hips shouldn't move. They could put their arms on top of their shoulders and then fix the scapula and then rotate, and you can measure kind of how far subjectively you feel they're achieving from one side to the other. Get them to do it really slowly, because when they do it quickly, it's harder to measure and read. And it is, again, it's quite subjective and it takes a keen eye. So just a little bit of practice, but keeping the nose level with the spine. So as they turn, you can almost work out roughly in degrees how far they can rotate one side to the other. Now, ideally, we should be able to rotate the same one way as the other way and at least 45 degrees to be good. Yeah. And that's without any scapular movement as well. So we've got to be strict when we're looking at that. When we move through the spine, generally in any direction, in flexion, extension, we should see a relatively smooth curve through the spine. So if you've got a client to sit and then flex forwards and look at what happens to the spine, you might be likely to see more rounding through the upper back, but it should actually come from all the way down, see a nice smooth curve. When they extend, generally that's going to come from lower down, but it should sweep up and can carry on up through into a little bit of the thoracic spine at least. And then in side bending, again, you could do all of these sitting. They're super easy ways to benchmark your client's progress in their spine mobility. So sitting on a chair, imagining they're between two planes of glass and just taking a side bend. You can compare one side to the other from the elbow bone or the medial epicondyle, how far they get one side to the other, how comfortable it feels or not. Now, within the spine, in fact, let me use this one, so I'm coming a bit closer. Within the spine, we have joints, and the facet joint is a key one to limit movement because we've got a spinal cord, we've got discs in here, and we really want those facet joints to limit movement. So a facet joint, I'm going to try and show you here. So you've got your spinous processes at the back, your transverse processes at the side, your vertebrae at the front of the body, so this is the back obviously, and then each vertebrae sits almost kind of into the one below, and there's a kind of an approximation of the bottom of the vertebrae above to the top of the vertebrae below. That connection is the facet joint, and what that means is it should almost be a movement limiter, if you like, so when you side bend you don't go too far and influence the structures of the discs and the spinal cord. So hopefully that all happens. Now, let's add in muscles, because that's kind of more our field. I'll just give you an example of one muscle. So the QL or quadratus lumborum. Quad because of the four sides, kind of, and lumborum because it's within that lumbar area. So it's going to go from the last rib down to the ilium. You can see how it's kind of almost already forming kind of a quadrangle. And then it will attach in, the books will tell you, to transverse processes L1 to 4 here. So it kind of feeds in. So it's not quite four sides because you've got those little fingers of QL that go in there. But it's kind of got the side, lateral side, the iliac connection, the rib connection, and then the little four fingers that go into the lumbar transverse processes. So if you imagine this muscle and you look at its kind of fiber direction, generally up and down, when it contracts, it will individually pull you over to one side. And effectively what's happening on the other side is the other QL muscle is lengthening, and vice versa. Due to its position within the body, if they were to work together, they would probably offer you a little bit of lumbar extension. The mechanical line of pull is not quite as strong as the side flexion or lateral flexion, but they will collectively extend. Now, I want you to imagine for a moment your lifestyle, your client's lifestyle. I would predict that anybody listening to this has a favourite carrying arm. Do you have a favourite carrying arm? If you went to the supermarket and you bought one bag of shopping, you will generally carry it in your favourite carrying arm, right? Tell me I'm wrong. Or do you swap? I've managed to get in the habit of swapping. So I want you to imagine you're carrying your shopping in one side. What is the weight on one side going to do to the QL on the opposite side? It's going to ask that QL to work harder to stop you from tipping over because of the weight of your centre of gravity has shifted due to the weight of your shopping bag. It's almost like going to the gym when we're allowed. One day we'll get there again. It's like going to the gym and you do your farmer carry or your suitcase carry with just one weight. And then what would you always do in the gym? You would always swap and do the other side, probably, right? But in lifestyle, any of you who have kids will probably have your favorite hip. Yeah, Robert, I know you're involved, you work with kids, I think you've got kids as well. You'll have a favorite hip where you've carried your younger child around. You'll always have a favorite hip. You might switch, but you'll pretty much always go back to a favorite hip, right? Anybody drive a car, automatic or manual? You're pretty much going to use your right foot, unless you're really clever. I've always thought about trying with my left foot, but I don't risk it, not while driving. So life is very asymmetric. There he is, Robert. Yes, exactly. It's getting a bit big now, but maybe you still carry him on your hip. So we have a natural tendency to strengthen through our lives one side of the body, probably more than the other. And this over time creates adaptations. So what? So let me come back to the original questions, which is talking around coupling. So what coupling is when you move, spine movement isn't really pure. So what happens when you, let's say you side bend, there will to some degree be an amount of rotation and flexion. And it's called coupling, and it's kind of a normal process. And it's a coupling because there's more than one movement, because you can't really, the way the body is designed, you can't move purely through the spine just because of its design. Its wonderful architecture means that you can't do really, really pure lateral flexion. You will have lateral flexion and a coupling of maybe rotation and flexion. So Fryet's law technically isn't a law, it's not fact, it's a set of guidelines designed by Mr. Fryet. And there are 3 principles, generally from osteopathy, I believe. And so understanding it's a set of guiding principles rather than pure fact. I think that might help if you start to read through any research you do into Fryet's law. Also, in reference to the original question from John Gibbons, I would suggest you go back to him if you have any further questions around his explanation, because I haven't heard it. But he's great actually at simplifying and helping people understand biomechanics and movement. But he's coming from an osteopathic viewpoint, so that clinical aspect. So I know he trains clinicians as well. So just keep an open mind and ask him to clarify for an exercise professional how we might interpret that. So they may talk about joints out of alignment, and that's really kind of that's kind of push all that aside. So let's focus on this coupling. If coupling is a kind of a normal response to spine movement, let's now imagine the compensation of an asymmetrical lifestyle whereby the QL muscle adapts because Rob's carrying his son on one hip and then maybe going to the shop and carrying the bag on one side, or, you know, maybe Brad has a favorite massage hand when he's a manual therapist and he predominantly uses left leg forwards, right arm rubs. And what we might do, somebody's ringing me, let me just get rid of them. What we might do is, it feels weird, doesn't it, to swap sides. You might do that, Brad, in practice, but you have kind of a side that you know you work well on a client. So let's imagine then a sitting lifestyle might be another example whereby the muscles of the hip adapt. These muscular adaptations can then create these functional asymmetries that can present in the ilium, maybe sitting higher on one side. What that then means is that there is a compensatory pattern while coupling that might mean when you do your lateral flexion, the coupling is a compensatory pattern as well. That doesn't mean that coupling is bad, and it doesn't mean you're necessarily going to be damaged or hurt at that point. But if it's a biomechanical dysfunction, it's an adaptation that doesn't get addressed, over time, the body's not ready for that position. It's not prepared. If we then load the body, strength training, exercise, picking up kids, going shopping, what can happen is then a client or we may experience pain or discomfort. Maybe my rugby friend over on Instagram would be an example of that. And I've got no idea, I'm not diagnosing, but just a way of thinking about what is right and what is going on when a client explains they have a sore back. So coupling in itself isn't necessarily a problem. It's a normal way that the body moves and compensates. But if you add in an asymmetry at the pelvis, then imagine when you go into flexion, trying to rotate is going to feel harder than if you are in a kind of a more level symmetrical position. So the coupling response, then it's almost like the body's not ready for that position. It's adapted and changed. And if you add load onto it as well, or repetition over time, that's when clients can experience discomfort. So let me just come back, because I know we've spoken about a lot and we had around about 4 questions right up front. So let me just check in with those questions, and also Marina, to see if there's any more. So Marina, feel free to tap in any extra questions that I haven't yet answered. So the first question was about, should the spine move in all planes? Yes. The degree of movement in those planes may differ based on the design of the spine, but we should see smooth curves and they should be comfortable and you know, and look good and feel okay based on norms. So do some research into the ranges and make sure the research is valid and reliable. So Stuart McGill's my go-to for spine stuff. We did the little experiment, didn't we, where Marina was asking about if the thoracic spine is stiff or not mobile, how does that affect the shoulders? Well, if you fix your spine into a position and then try and lift your arms, then you'll recognize that actually the shoulder motion requires a mobile spine so that the shoulders aren't doing too much or being restricted or limited in some form, which can then open up risk of injury. Emotional impact and the connection between thoracic spine and the parasympathetic nervous system. So I sent Marina away to go and do research, not my field. However, having worked with an osteopath and a client with thoracic pain, understanding emotions with that, you know, I've had the tiniest bit of experience, but I wouldn't for a moment try to respond to that question. So I've signposted you back to our KUNTZ professor. I'm not going to say it. And then number 3, if muscles can permanently change skeletal structure, just understand that statement and what that means. It can, but not in all cases. So just try and understand the definition of that. Can giving exercise really counter the damage? I think what we're trying to look for here, and I know Marina will know this, and I know she understands this, good movement doesn't need to be on perfect lines. We may be genetically asymmetrical, but the more we can work towards quality movement that feels good and looks kind of more symmetrical, we're going down the right route. So rather than expecting perfect symmetry, we're working towards it with functional movement in mind, rather than perfect level pelvis, perfect level shoulders. Somebody my age, coming up to mid-50s now, you know, I've been around a little while. I do have bunion formation on one foot. I have a biomechanical dysfunction that then comes back because of that. So doing the ibuprofen exercises reduces the risk that has developed because of that structural deformation. So I hope that makes sense. And then understanding the central axis of the spine and coupling. And again, it's really a language that's normally spoken about in clinical terms. So I think when we as movement professionals research these terminologies, which we should, we need to keep an open mind of the context and remember to ask, do what Marina's done, ask, do the research. So I went and spoke to my physio colleague about this to help me answer the question. And to understand a little bit about a clinical perspective of what it means. So just understand if you're going to go and speak to or listen to a clinician, and I would just ask. I know that John Gibbons is really open-minded, he's great at, I mean, he can talk. He and I are both similar in that aspect. Go and ask John, touch base with him on social media. He's putting a load of content out there. His books are really popular. I've got one of his pelvis spine modules online, and he's done a load of videos on YouTube, so go back to him. But understand, he's an osteopath, he's clinically trained, so his language and perspective, we need to check that we're staying within remit. So that would be my guidance there. So Marina, any further questions based on any of that, or anyone out there? Let's have a little look over on Insta. Still got a few over there. Let's just check in, and I'll just wait and see if Marina's got any further questions. Rachel over there. Hi, Rachel Hill. How you doing? Hi, Francesca. Got quite a few over there. Hi, Tanya. No twerking on here. Tomorrow morning is the twerking session, so if anybody's up for a twerk. Okay, so any questions, guys? Do you, would you like me to go through any more of the anatomy, or are you good with that side of things? Just go over onto Facebook. Sorry, hi Louise, hi Roz. Any questions over on Facebook? Around, we'll keep it in spine biomechanics, I think, just to sit in with everything we've spoken about so far. See who else is over on. Amelia, how you doing? Feel Good Fitness, how you doing? All right, crowd in. So, okay, so let's just pull this all back together. The spine's a pretty robust structure. It takes a long time to hurt your back, to really hurt your back, in my experience, unless obviously you have impact trauma. So what I'm talking about is a back problem that is insidious. It creeps up over time. So when you bend over and pick a feather up and your back tweaks, that has been an underlying issue for a while. That doesn't just happen. There would have to be an underlying medical condition, or if you've had previous trauma. But biomechanically, problems that occur, common issues within the spine, pains and aches, can often result from things that we can address earlier on if we understand how to evaluate and appreciate the way our client's spine should move. So learn more about spine biomechanics. As I've said, over on the Biomechanics Education blog page, you'll find a couple of blogs around the spine bones, the spine muscles. We talk about the anatomy. We've got a low back health module, which there's an online CPD with a recording and a PDF with that you can go and get to 197, I think. Talks about clinical aspects of spine biomechanics. It's got the ranges in there, so how much range we should expect from lumbar and thoracic spine through flexion, extension, rotation. Definitely go and have a check out of Stuart McGill. I've mentioned him a few times, his book, Ultimate Back Fitness Performance, but you can go and if you skin, which a lot of you are right now, I know exactly how you feel, just go onto YouTube, stick Stuart McGill in. He's a really nice guy, fantastic mustache. So, and really cool. He's done a load of kind of bro science type videos, T-Nation, there's another bro science group over on YouTube, some MMA stuff, but he makes it all relatable. He talks about it with athletics clubs and athletes that he's worked with, but he does make it make sense. Last week, if you want to watch last week's Q&A, I think it was last week, we talked about the effects of being in zero gravity and the hydrostatic pressure and the osmotic effects of lying down. Yeah, I know, I learned a bit. So go back, you can look at that. That's over on YouTube. Last week's Biomechanics Q&A was an interesting one. But his book, he definitely wrote with us in mind. There's also a small book he wrote called The Back Mechanic, which is for clients to understand themselves why they hurt, and that kind of psychological aspect of back pain, which he, again, sort of advocates understanding, giving clients confidence to move is a big part of what we do. So in a nutshell, Marina, use every range. Don't be afraid to move. Understand your client's biomechanics in terms of which direction is limited and maybe why. So based on the tests you're learning with us, that at the moment you're just doing online. Obviously, when we get back to face-to-face, when Boris allows, we can do more and find out even more about your pelvis and spine biomechanics and everything else. But look at, and this is a key message here of everything I've spoken about, within your scope of practice, what are the least contraindication techniques you can prescribe to a client within your remit to improve their biomechanics? So understanding muscle energy techniques, I know John Gibbons, he also talks about muscle energy techniques, but understand the differences. So we're not talking about PNF is a muscle energy technique, that's quite an aggressive one, and you might need a bit of help, or your client might. Understand Rebo Siskar's post-contraction sensory discharge that we teach on our I'm Move Freely course. The wall glides that are an accessory move that help to release this QL muscle that we talked about earlier, that might inhibit or feel restricted when you side bend as a result of carrying a bag on one side or children on one side. And they can be such low-grade, safe, easy techniques and interventions that keep us within remit, as long as the client doesn't have any red flags or pain, or we put them through a safety net system online to get them cleared first, to understand what exercises we can use. It doesn't have to be loads of strength load or planks, or, you know, some things you may feel nervous about giving to somebody who's uncomfortable. Whereas using low grade techniques in other parts of the body, rather than the area that hurts, can take pressure off it, but keep us within our remit, start to build confidence in our clients about the fact you can move, there is something we can do, there is something that can help with. So hopefully that helps. So Peter, repetitive movement wear and tear has been my issue, but exercising and regular physio definitely improves spine mobility. Yeah, exactly. Mags, do you think we can talk about nutation and counter nutation of the pelvis in the next sessions? We can, but I would need to understand exactly what the question is, Magda. So send me like a full question. Tell me why you want to know. Neil, do you do these visual sessions regularly every week at this time, Neil? 12 o'clock, all of lockdown. If you want to watch the other ones, they're all on the YouTube channel. So go over to Biomechanics Education YouTube channel, subscribe, you won't ever miss one. But we are live every week. Neil, if you've got a question, send it in, and maybe next week we can answer your question. No pressure, Rach. Please understand, my view is a very small and biased view of bodies and anatomy and everything else. So I'm just sharing with you the things I've learned. So I would be more comfortable sending you and signposting you to research other practitioners and professionals' opinions as well. Don't just take mine, please. Don't just take mine. I'm just teaching you what I've learned. And so definitely go and explore. Stuart McGill, John Gibbons, Robert. If someone is very tight through pec minor, could it be a reason of pain when throwing? Yeah, it could be. So could a whole bunch of other things. So it might be that we do some pain science next week because of the questions coming in. Just having a look over Leanne, a load of stuff coming through. So with training and concentration on the posture side of things, do you reckon you can get your posture back to how it should initially be? Leanne, we did a whole, you're welcome, Neil. We did a whole Q&A about 3 or 4 weeks back, all about posture. Posture is just a position. No posture is contraindicated unless you hold it for too long with too much load that the body isn't ready for. Tissue tolerance, load management, Tim Gabbett, great workshop. So another reference there. And these are just people I admire, I've learned from. These are experts in their field. They do research, they know because they've done the data, but they're also people who make it simple to understand. You know, it's all right having loads of knowledge. It's got to apply to Barry in the gym or Ethel with her Zimmer frame going to the shop and back. So always make sure that you get back to the point of context. Tim Gabbett, Gabbett. He's over in the other side of the world. He's doing quite a bit on social media at the minute. He's very much performance-based, definitely evidence-based, and he's clear on what is evidenced and what is not. But he's definitely talks about tissue tolerance and load management. And it sounds elitist, and certainly in his field, you might see it that way. But for us, who are maybe working with a regular client at home who just wants to lose a bit of weight or have their back feel better, or Rob's guy who's got a bit of a sore shoulder, putting everything back into context, how best can we help? Test, monitor, prescribe with, you know, the lowest contraindicating techniques first, and within your remit, gradually build up a tissue tolerance, manage the load that your clients experience over time, understand their movement qualities, and keep remeasuring them. You can do it online, just like I am here. If I got you all to sit on your chair and side bend, if I could see you, I could take a measure, I could record that or snapshot it, and then get you to do it again next week. See what it looks like. How's that feel? Well, it feels a lot better, thanks. Brilliant. Keep doing them wall glides. Doesn't have to be complex. We just need to know that we're within our scope and how to help people. So I think that's it. That's all right, Leanne, no problem. I think that's everything. Ooh. Okay, Keris, you're very welcome. Pain science is a really interesting one, so I've definitely got some guidance for that. We'll maybe do a bit of that next week. Come back next week, pain science. We'll keep going whilst we're locked away. Let us know what more you want to talk about. We've got pain science, and maybe Magda's going to come back with a question around pelvis movements later on as well. Anything else? Yes, next week, guys, before you go, next week, February 19th in the morning, I've got 3 experts in mindfulness, mindset, and mental health. It is a morning of sessions about how can we help ourselves stay mentally strong and robust, and then how can we pass that on to clients. Go and have a look. It's on my pages everywhere. You'll go and find it. It's on the website. Click on workshops, online CPDs, mindfulness, mindset, mental health workshop. It's not me. It's not my expertise. I need their help, which is why I put it on. So let's stay motivated. Go and check that out. And I'll see you on Wednesday. Pain science. You up for that? Keep moving. See you next time. See you, Insta.
Thank you.
Zoom, guys. Nice to see you. Oh, and your doggy. Mine's disappeared. He's gone. He's probably gone in the house, back to bed. Next week, guys. Thanks, Marina.